The Nebraska Cancer Research Center, in partnership with Bryan Health, Nebraska Hematology Oncology, St. Elizabeth Regional Medical Center, and Southeast Nebraska Cancer Center presents.
Hi, I'm Dr. Mark Hutchins from Lincoln, Nebraska, a practicing medical oncologist. For this portion of our program, we'd like to entitle it Breast Cancer, Have We Gotten the Cart Before the Horse? So when we see ladies with breast cancer and families afflicted with breast cancer through the years, it's become evident that the real concern of ladies and their husbands or their spouses and their families are in fact whether the breast cancer will stop them from seeing their grandchildren. Will they live long enough to see their children graduate from high school? Or in some cases, will they even see their children finish grade school? So the real concern when an individual is diagnosed with cancer in general, and breast cancer in particular, is will this have an effect on my longevity? Will I be able to live out my normal life? Will I be able to live my normal life with a normal quality of life? So the real concern about breast cancer is not about the breast. It's really about mortality. Dr. Bernie Fisher in the 1970s and early 1980s contributed perhaps the greatest research contributions for women in breast cancer in the last 50 years. His hypothesis is that the majority of ladies diagnosed with breast cancer have cancer cells that have already spread by the time the cancer is diagnosed. It's not very well known, but it's well established now that by the time we diagnose breast cancer, even with just a mammogram, the cancer has actually been in the body for several years. It's estimated 3 to 6 years in most cases. During that time, the cancer cells may or may not have already spread to other parts of the body. Dr. Fisher's hypothesis is that the majority of patients did have cancer that was already spread. And if that is the case, then local regional treatment, i.e. mastectomies or lumpectomies, should not have a great deal of influence on mortality if the cancer is already spread in the majority of cases. The other hypothesis is that by giving effective systemic therapy early, then we should have an effect on mortality. So the traditional approach up through probably the late 1980s or to mid-1990s for women with breast cancer after a diagnosis was made was to proceed with surgery. Acting on one of those hypotheses, Dr. Fisher and others then started large clinical trials testing the hypothesis that early effective systemic therapy, in some cases chemotherapy and in other cases hormone therapy, was given early right after surgery was performed. What those trials showed was that early therapy, both chemotherapy and hormone therapy, did in fact change the mortality of women with breast cancer. So the traditional approach was to proceed with surgery followed by early effective therapy, either chemotherapy or hormone therapy. A new concept came about in the sense that women with early breast cancer could in fact be given early systemic therapy even before surgery. And when that approach was performed, the following results became available. Women were randomly assigned between receiving chemotherapy followed by surgery or surgery followed by chemotherapy. The women could choose whether or not they wanted a lumpectomy or a mastectomy up front. And then they received the surgery and then the chemotherapy, or vice versa. They were given the chemotherapy first, followed by the same exact surgery that they would have had. Unless, of course, the tumor became so small that they decided to have a lumpectomy. Several things were shown in that study. From this slide you can see the survival and the disease-free survival, meaning the time to the point when the cancer came back, were both identical in both arms of the study. Whether a woman had surgery first followed by chemotherapy, or whether a woman had chemotherapy first followed by surgery, her survival and disease-specific survival was identical. What also became evident is that by giving the chemotherapy first, many women qualified to receive a lumpectomy or breast-conserving surgery who would not have qualified for that before. The other thing that became apparent is shown in the next slide. Women who enjoyed a complete eradication of their cancer, and by that we mean when the pathology doctor looks at the specimen after the surgery was done, either the lumpectomy or the mastectomy, the pathology doctor, try as they might, they couldn't find any viable cancer cells. We call that a pathologic complete remission. It became evident from these studies and many other studies that have been done since that if we achieve a complete pathologic remission by giving the chemotherapy first, the women have a very high chance of long-term survival. And what this means, of course, is that the response in the breast is a marker or a surrogate marker of the response of the cancer cells that might have already spread to someplace else in the body, say, for example, the liver or the lung or the bone. Nowadays, we've even developed biologic markers so that we can biopsy the breast before surgery is done, before chemotherapy is given, with a small needle biopsy. That tissue can be analyzed by genetic molecular biologic markers, and we have the ability to determine, based on those markers, whether women will likely fall into the category of complete pathologic response. This gives us the ability up front to determine who might best receive chemotherapy at all and who might best receive chemotherapy in the preoperative setting to achieve a complete pathologic response. These and other studies are being undertaken internationally across our world currently. The doctors in Lincoln are taking part in these studies as a member of the Nebraska Cancer Research Center and the Missouri Valley Clinical Community Oncology Program known as the CCOP. Patients in Lincoln, Nebraska and Omaha who see these oncology doctors have the opportunity to take part in these prospective clinical trials. It's important to realize if you have an opportunity to take part in a clinical trial testing two different types of pre-operative chemotherapy, it's important to know that giving the chemotherapy in the post-operative setting does not reduce your survival. Delaying the therapy to get proper testing done before chemotherapy is started, or delaying the surgery until the chemotherapy is given, does not decrease your chance of long-term survival. Thank you.
Home is where you celebrate life. Home is where you spend time with loved ones. Home is where you cheer for the Huskers. And when you're diagnosed with cancer, home is where you want to be. The Nebraska Cancer Research Center offers hope right here at home in Lincoln. Ask your doctor about participating in cancer research. The Nebraska Cancer Research Center. There's no place like home for clinical trials.